Well, good morning, everyone, and welcome to the fourth annual Jack Cogan Integrative Medicine Grand Rounds lecture. My name is Peter Wayne, and I serve as the director for the Osher Center, which is jointly based at Brigham and Women's Hospital and Harvard Medical School. This named lecture honors the memory and remarkable life of Jack Cogan and is generously supported by a gift from his wife, Mary Corneal, in appreciation of the supportive, integrative care that Jack received at the Osher Clinical Center. I'm so delighted that Mary is also able to join us today online for this lecture and celebration. Jack lived a very long, remarkable, and highly accomplished professional life, and he's also very socially active and served on many boards and civic and charitable organizations, both in Boston and internationally. Yet despite his remarkably busy life, Jack always understood the importance of maintaining a healthy body and mind, which is most evident in his lifelong passion for running, which he continued to do well into his 90s. I had the privilege of meeting Jack a few years before his 90th birthday and introducing him to Tai Chi to support his balance and his ability to continue to run, despite challenges he was facing associated with advancing Parkinson's disease. Jack's commitment to mind-body health also led him to our Osher Center, where he took advantage of numerous neuromuscular massage and movement-based movement therapies that we offered in an integrative way. All of us who had the privilege of working with Jack were deeply touched by his zeal for life and happiness and his commitment to overall wellness, while he also worked with his medical team to manage symptoms and the progression of Parkinson's disease. This theme of navigating a path committed to whole person health while managing complex medical conditions will be one in our special lecture today to be delivered by Dr. Wayne Jonas. But before Dr. Jonas's talk, I have a few announcements I'd like to share. First, I want to invite you all to be aware of a virtual symposium that's going to take place on November 8th, which is at the intersection of integrative medicine and planetary health, a program that we've initiated here at the Osher Center led by Atra Nusrat. This symposium is being organized by our larger Osher collaborative, which includes many other centers. We also have a really exciting symposium, two-day network forum that's going to happen December 9th and 10th, and it's at the intersection of high-tech medicine and soft touch healing. And in particular, we're going to be looking at how technology, including wearables and in-place sensors and technology, as well as quantitative tools like AI, can help understand the effectiveness and mechanisms underlying integrative therapies, but also conversely, how the unique questions we ask in whole person health and integrative therapies might drive innovations in technology. Very exciting. And I want to mention that both of these, as always, are free to attend and open to the public. And then finally, I want to alert our community to our research pilot grants. Our letters of intent for our 2025 cycle are due January 15th, and we've increased our gifting to $120,000 for up to 4 collaborative projects. And moving to more practical matters related to the seminar today, if you're interested in CME credit, please follow the instructions on this slide. And then finally, during the Zoom seminar, as you're listening to Dr. Jonas's talk, if you have some questions you want to share with him, which I'll present at the end, please put those in the Q&A box. I'll be curating those, and we can introduce those to him at the end of the seminar. So now it's my distinct pleasure and honor to introduce our distinguished speaker today, Dr. Wayne Jonas. Dr. Jonas is truly a pioneer in today's field of complementary and integrative health and whole person health. And he was the founding director of the Office of Alternative Medicine at the National Institutes of Health from 1995 to 1995, which later evolved into its own institute, which is now the National Center for Complementary and Integrative Health. Dr. Jonas is a board-certified practicing family physician, an expert in integrative health and whole person care delivery, and a widely published scientific investigator. Additionally, Dr. Jonas is a retired lieutenant colonel in the medical corps of the U.S. Army. From 2001 to 16, he was president and chief executive officer of the Samueli Institute, a nonprofit medical research organization supporting the scientific investigation of the healing process in the areas of stress, pain, and resilience. Dr. Jonas wrote the best-selling book, How Healing Works, laying out a revolutionary new way to approach healing, illness, and wellness. And he's also author of a fascinating new book I highly recommend called Healing in Cancer, A Guide to Whole Person Care. Earlier in his career, he served as director of the Medical Research Fellowship at the Walter Reed Army Institute of Research, and he's a fellow of the American Academy of Family Physicians. Dr. Jonas's leading-edge research has appeared in many high-impact peer-reviewed journals such as JAMA, Nature Medicine, the Journal of Family Practice, Annals of Internal Medicine, and Lancet. And his contributions have been acknowledged with many awards, including the Pioneer Award from the Integrative Healthcare Symposium, America's Top Doctors Award, and the Physician Recognition Award from the American Medical Association. Dr. Jonas is currently the president of Healing Works Foundation, a not-for-profit organization dedicated to the integration of healing and curing in routine healthcare delivery. The title of Dr. Jonas's talk today is Cancer in the Context of Integrative Medicine and Whole Person Health. And so without further ado, please join me in welcoming Dr. Jonas.
Hello, everybody, and it's a great pleasure to be here. Thank you, Peter, for that introduction, and thank you all for your flexibility in adjusting this talk. I'm sorry that this has to be done virtually instead of in person. It would have been very nice to come up in person. I'm also grateful that this can be done virtually, and so that we can actually have this time and share from many places and any place in the world. I've never quite figured out why the name Wayne shows up sometimes in the first name, some Peter. We can have a discussion offline about how that happened for you, and we can kind of figure that out in those areas. So let me bring my slides up, and we'll begin the talk. And I think over the next 30 to 40 minutes, I'd like to talk to you about what is whole person care, and then how it gets delivered. And I'm going to use cancer as an example of that. And let's see now. Let's make sure. There we go. Okay, can people see those slides, and can you hear me all right? Good. Okay. Let's see now, make sure I can move there. Okay, so first, my disclosure slide. Always obligatory. I don't have any disclosures. I'm fully funded by a nonprofit organization that is not involved in any commercial efforts, both either in conventional or in complementary or alternative or integrative practices. So I have no financial disclosures in these areas. You've seen my bio, and thank you, Peter, for giving such an overview and thorough overview of that. In addition to disclosures, I'll make a disclaimer. I really am here to try to empower people, and I'm really grateful for the ability to do that. Everything you're going to see in this lecture that we've done, except for one exception, which is not ours, is totally free, and it's on our website, and it's available. And I encourage people to take it and use it, rebrand it however you want to advance healing in healthcare. What I'd like for the listeners to get today is the following. First of all, I will define what whole person care is, especially in the context of cancer, and I'll illustrate its rationale and the science behind it. I'll summarize how bringing the patient into their own care and process actually increases and optimizes both the quality and the length of life. I'll review some examples of whole person care occurring in oncology, many of which bring in integrative practices, but it goes beyond that. And I'll introduce you to some tools that a whole network of groups have developed, both in primary care, in general medicine, and then specifically in cancer care recently. The goals of the foundation that I run now, which started about a year and a half ago, is really to make whole person care routine and regular. Our interest is getting this mainstream, getting this something that you walk into an office for a visit and people ask about the following questions that I'm going to show you and begin to provide support and resources to support healing and person-centered care in those areas. Well, before you can talk about whole person care, you have to know what the person is. So, if we're talking about a whole person, what do we mean by a whole person? And what I like, and I think has been durable over 70 years, that really describes what the fundamental needs of all human beings are to flourish, are Maslow's hierarchy of needs. And you can see that on the right side of this graphic. In which he described the basic physical needs, the safety and physiological needs, then the psychological needs of esteem, belonging, love, and then finally what I call the spiritual needs. Most people realize that self-actualization was at the top of his hierarchy for most of his life, but what few people realize is that toward his end of his life, he changed the hierarchy and he added something on the top. And there's a number of articles about this, which he called self-transcendence. So it was beyond self-actualization. It was the experience of really spiritual awakening and the giving back to the community beyond self in those areas. And I think that really put the cherry on the top of his hierarchy in those areas. And I still think it is one of the best ways to knowing what should we be providing individuals if we want them to flourish. Now, since then, I should say, over 70 years ago, we've discovered a few things about this that have changed our understanding of it. Number one, it's actually not a hierarchy. Yes, you do need basic needs, and it is struggling to struggle if you don't have them. But all of these needs are important, and it doesn't go in a hierarchy. It's not like you first get your basic, then psychological, then the spiritual needs. There are many individuals and groups that don't have really the fundamental basic needs, and yet they're very strong in psychological and spiritual components, and it supports them in their health and well-being and resilience. And we all know people that have all the basic needs that they have completely filled, and they never quite get to getting out of loneliness, social support, and meaning and purpose in their life, the spiritual needs. And so it's not really a hierarchy. It really is a sphere, if you will. And so we've reorganized Maslow's hierarchy into the figure you see in the middle of this slide and have tried this out in healthcare settings to really help people see what a whole person is and not miss any of the key drivers of health, of which we know 80% lie outside of the current way we deliver medical care. And so that middle figure illustrates this, and it illustrates it in a concentric way because it's easier to see the things on the outside, right? The body and the physical components are the things that we deal with most easily in medicine. But underneath that are key behavioral and lifestyle components that are a key part of human flourishing that fulfill these needs. The social and emotional are the next layer. And you don't have to have a mental health problem to have a social and emotional need in those areas to drive your health. And then finally, at the core and at the center, and this is what's really important for whole person care, are the spiritual and the mental needs. And I'll illustrate what we mean by that and how we use this framework derived originally from from Maslow, but reimagined for healthcare and modern healthcare today to enhance the dimensions that drive healing for a person. So once you know what a whole person is, then it actually becomes relatively simple to actually provide that type of care. Now, I won't say it's simple in the context of the way we do things normally, but conceptually it's pretty simple. You start at the center, at the spiritual mental component, by asking the person what is most important for them in their own life. That is what matters. This is sometimes called person-centered care. And some of the questions include what supports joy and meaning in your life. And I'll show you some tools that help have that conversation. Then you don't forget any of the 4 dimensions of a person that I've illustrated: the body, the behavior and the lifestyle, and the social and emotional and the mental. You explore all of those. You ask questions about those, and we get into trouble when we neglect those things. If we ignore those and we just treat the person as if they were only part of a person in those areas. So we truly are holistic in that sense. And then the third part of it is that we bring tools, resources, and activities that are salutogenic. That is, they drive the creation of health and not simply put a treatment on a disease once it's manifest. And so this comes down to finding out what are the personal determinants of health, what are the drivers of health, and supporting those for an individual. So these three elements are really how whole person care, in my opinion, is delivered. Now, I introduced this term salutogenesis. Many of you may have heard this before, but let me highlight it a little bit because it is key. I learned, and I think we still teach medical students from the book of pathology. And we teach them about pathogenesis, which is, as the Latin describes, pathos, disease, genesis, the creation of disease. And interfering with those processes very often after they've manifest late in the game. And treating disease and illness is where the vast majority of medical care is focused. But there is a parallel process going on, and the biology of this is very robust. And it goes by the term salutogenesis, saluto meaning health, genesis, the creation of health. It's not simply prevention, it's actually the process whereby health is maintained and is recovered if there is a disease, and in wellness is improved if the disease can't actually be recovered. And so it is the facilitation of health and well-being that is salutogenesis. And here's where behavioral and integrative health is essential and shines in those areas. And this is where the focus of whole person care needs to be. Now, I want to use cancer as an illustration of how this occurs. Now, the first book I wrote, How Healing Works, and the network of tools that we developed were in general medicine in those areas. But there's nothing like the diagnosis of cancer to help you focus on what it means to take care of the disease and what it means to take care of the person. Here's an example of an individual kind of bopping along in their life, and this is what fills up their mind and emotions: politics, romance, activities, the internet, etc. And suddenly somebody says you have cancer, and when that happens, it pushes almost everything else out. And it creates fear, anxiety, and suddenly you engage the medical profession, especially oncology, around this. And it takes over your world, as that graphic illustrated. And so the person's world and the provider's world now intersect and clash. And suddenly all the power is over on the right-hand side of this, the oncology team, and your life is filled with labs and scans and surgeries, treatment plans, toxicities, clinical trial eligibility, and most of the stuff on the left-hand side goes into the background. And unfortunately, what's on the left-hand side is just as important for the quality and quantity of life in cancer, as I will illustrate, and in many other chronic diseases. Here, let me show you an example of this from a patient that I will call Jan. This is a real patient, but it is not her name. She got cancer early, and unfortunately, this is happening more and more. I just had a patient contacted me the other day, 38, with advanced colon cancer, and we've seen the lowering age of colon cancer occurring, and that's occurring in other things. But Jan had breast cancer when she was 34. She was a mother of young children, had a very busy career. And then she got it treated effectively. But over the next 30 years, she was faced with 7 different types of other cancers that occurred in those areas. So she was living with this diagnosis over that period of time. Now, if you went to the medical record, if you went to her summary of her record from her oncology team, what would you would see is that you would see stages and treatments of her cancers that came along, detailed classifications of her treatment plan, and various other kinds of things. Now, the genetic aspects, which didn't exist in 1991, but now are an important part of cancer, and you would see a variety of things in her medical record. But what you would not see actually is what was important to Jan. And very little of what impacted Jan over that period of time would have been documented. And here's a list of the things over that 30 years that she experienced with this particular diagnosis and living with cancers as a chronic disease. Fear and no time. She ended up quitting her job. She got chemotherapy, put her into early menopause. She gained weight, very important. Insomnia, loss of libido. And then as cancers kept coming back and she engaged over the cancer plan. Often nobody was really in charge. And very little of the things that impacted Jan's life actually were documented in those areas. Now, fortunately for Jan, since 1991, when she had her first diagnosis, the cancer mortality has dropped by over 33% for a variety of reasons. So we now have over 4 million people that are alive that wouldn't have been alive had they remained at the same rate. So that's great. The unfortunate thing is that because of aging and other environmental factors, perhaps there's a growing number of Jans out there. It's estimated by the National Cancer Institute that there will be added an additional 7.9 million cancer survivors, up to 26 million by 2040. And so we're going to see a lot of people like Jan with chronic disease as cancer. And this means that taking care of them as people becomes even more important. Now, why has this drop in cancer mortality? Well, one thing we know it's not from largely is because of all the breakthrough treatments that we're having. For individuals, especially with the advent of precision oncology, immuno-oncology, there are breakthroughs. There's no question about it in certain types of cancer or subsets of individuals, and those are fantastic. But if you look at the overall effect of FDA-approved drugs over a decade and a half, these drugs have only improved median overall survival by about 2.8 months, and often at great cost, as you can see on the left-hand side of this. So why is this occurring? Well, the major reason actually has to do with prevention, and that includes screening and lifestyle. It's estimated that over 40% of cancers are preventable. The biggest drop has occurred because of drops in smoking and smoking cessation, as you see on the right-hand side. Unfortunately, that's been offset partly by obesity and other kinds of behaviors that you can see listed in here. But over 40% actually are due to that. If you remove smoking, at least 18% of all cancers diagnosed are related to things like body weight, inactivity, alcohol consumption, poor nutrition. And if you combine that with early detection and screening, which we're gaining more and more, this explains a lot of the drop, and we should focus a lot of those. The problem is that often focusing on those behaviors once you have cancer is a delicate thing. How do you encourage behavior change without blame? I've had many patients that have come to me and said, well, I eat right, I'm a vegetarian, and I exercise, et cetera, and I still got cancer in those areas. And so we'll talk a little bit about how to do this. The health span, those determinants of health for whole person care I've just talked about, they operate before and after a diagnosis, regardless of what the diagnosis is. And yet, once the diagnosis occurs, especially in cancer, we mostly focus on lifespan, and we tend to neglect the health span in those areas. So whole person care is bringing that health span and making sure it doesn't get lost in the discussion post-diagnosis. The other thing, especially in cancer, but for many other chronic diseases, is that we know that the science, the biological science, also calls for whole person care. 50 to 100 years ago, we thought the tumor was a rogue cell. It just escaped growth controls, and suddenly we just had to get rid of it. And so surgeries and chemotherapy and radiation, many of the treatments that we still have prominent today, was the primary thing. And go back and read The Emperor of All Maladies by Siddhartha Mukherjee if you want to see how that framing of tumor occurred. But we now know that that's not actually how it happens. that the cancer occurs because of a dance between not only the tumor itself, but the environment. It's called the tumor microenvironment. And here's a slide that illustrates the hallmarks of biology of cancer, showing multiple physiological processes related to metabolism, immunity, inflammation, the microbiome. That the basic science of cancer and cancer processes are now showing us emerge. So there really is more to it than simply the tumor. The environment makes a big difference. And breakthroughs in immunity and treatment and inflammation are key there. Here, let me just pick one of these out, chronic systemic inflammation. Here's a summary of the impact of inflammation, chronic systemic inflammation, on a variety of chronic diseases on the right-hand side, published in Nature Medicine several years ago. And if you look on the left-hand side, you'll see that the contributors to chronic systemic inflammation are some of these same behavioral and lifestyle factors that we've talked about, from obesity to inactivity to diet, isolation, disturbed sleep, etc. And they contribute to multiple chronic illnesses, including cancer in those areas. And in fact, if you drill down on just inflammation and cancer, there's extensive data now showing that the tumor microenvironment, just looking at the inflammatory aspect of this, is directly linked to the tumor macroenvironment, or those same behaviors that I illustrated before. And so one cannot logically say I'm using good science in cancer management or chronic disease management without talking about the macro environment, and those are the core aspects that we call wellness and wellness behaviors. The inflammatory, immunity, metabolism, microbiome components are all influenced by things like diet, activity, sleep, social support, and love in those areas, those behavioral components. And to engage individuals in that requires that we find out what matters to them at the time and begin to support them in making those kinds of changes beyond the physical components to really whole person care. The epidemiological and clinical trial evidence for the importance of engaging in these wellness behaviors is also emerging. So not only does the biology explain it, but also we're seeing it clinically manifest. For example, 10% increase in the amount of ultra-processed food increases a greater than 10% risk in cancer. Walking as little as 30 minutes a day lowers the risk of 7 different types of cancers by 6 to 18%. High levels of social support compared to low levels of social support can reduce mortality once you're diagnosed with cancer by up to 25%. That's greater than all the drugs that we've talked about before. And that there are a number of quality of life indicators that influence all of these things. For example, almost 60% of cancer patients experience disordered sleep that then influences many of those hallmarks that we talked about, as well as quality of life. So it's important that we address these behaviors. But how do we address them in a way that results in engagement and hope and not guilt and blame? I mentioned to you that I have many patients that come and say, how did I get this? I try to eat well. I try to do all of these things there. And so we cannot actually say that cancer is produced. They're influenced by them, but they're not caused by them. And yet engaging in behavior still can enhance a person's quality and engagement. And so this is the delicate dance of whole person care, not imposing behavioral and lifestyle aspects, but identifying what matters to the individual and moving that forward. People want to do this. This isn't just supported by the epidemiological and the basic science data. It's something people want. If surveys that have been done about the use of complementary and non-drug approaches, whole person approaches, this is 2 surveys, national surveys, the results done back-to-back over 2 years that our foundation supported, and showed that the majority of individuals are interested and want to engage in some kind of activity. 90% nutrition programs, mental health support was important for over 60%, 78% were interested in spiritual care of some type or social support, 60% for spiritual care. And that same survey that looked at what was being provided by institutions, these are mainstream institutions around the country, randomly selected, 96% of them had at least one of these components of supportive cancer care available, and there was an increased intention and activities to provide them. Now, what Jan experienced is that in the various oncology groups that she had, these services were available. And yet they weren't coordinated or integrated to make them accessible, because there were gaps in terms of what was available and what patients and oncologists offered, even within their own organization. So it wasn't that they couldn't have them very often, but they actually just didn't have their practice organized in a way to make them available, especially in the area now where there's extensive evidence on exercise, also other areas like massage and meditation and mindfulness. And we'll talk a little bit about that. So if Jan had had these kinds of whole person care aspects available in her organization, her treatment approach would have looked a little different. Her joint pain, for example, could have been mitigated with things like acupuncture and hypnosis, fatigue and insomnia with exercise support, yoga, sleep CBTI, and even sometimes medications would have helped. Depression and weight gain. No one talked about weight gain that occurred after she went on chemotherapy at 34, and that increased her risk for the other cancers that came along, but she didn't get even offered a nutritional concentration or support in terms of maintaining her weight. Loss of things like libido for quality of life, and then later on, as other cancers began to emerge, palliative care was brought into the discussion, even though it was recommended that it be brought in within 8 weeks of her first diagnosis to help her manage coordination, navigation, and fear and hope. So had she had a discussion about what mattered to her through her 30 years, these things could have been offered in parallel with the treatment components of that. So fundamentally, it comes down to a very simple process. My colleague, Alyssa McManaman, an oncologist of years of experience, says that any clinician can deliver whole person cancer care, because at its core, whole person cancer care is about seeing an individual beyond the disease or the illness and learning about and partnering with them on what matters to them now. That first question that I mentioned at the beginning of this talk, what matters to you now? So if you saw Jan now in her cancer journey and you said, what matters? She would tell you this. She'd said, you know, I've got 3 grandchildren and I want to spend time on Friday afternoons that his parents have set aside that we can hang out with my grandchild. And this is number one. The social support aspect is very important in those areas. And if that importance was brought into the team management, then she could have accommodated within her treatment plan what mattered to her now. And having done that over the 30 years, she could have gotten all those other things that I listed before. And so this requires coordination of the team for the delivers cancer care, because we now deliver it as a team. This means navigators and advocates have to be present and empowered to actually bring what matters from the patient into the team discussion. It should be part of case conferences in those areas, and there's examples of that going on. And it should be embedded into the personal health care plan and the electronic medical record, so people see it right up front in those areas. The importance of doing this has been declared by leaders in oncology. Even recently, here's 2 quotes by the former past president of the American Society of Clinical Oncology, ASCO, Eric Weiner, who said, oncologists harbor concerns that they don't have time to establish a partnership with each of their patients, but they must establish these partnerships in order to provide the very best care. And then this year's ASCO president, 2024, in our presidential address, talked about the importance of the art of cure, engaging with patients and their families with deep compassion, understanding, and weaving supportive and palliative care to be an integral part to achieve the best possible outcomes. So whole person care is being recommended at the very top of cancer care. Whole person care is also being recommended within guidelines that oncologists are encouraged to follow that are evidence-based. And here's three recently that have come out, done by the Society of Integrative Oncology and a joint ASCO committee for whole person care, one on pain management in 2022, anxiety and depression and fatigue. Our foundation is supporting two others that'll be coming out in the next year in those areas. These can be joined by other guidelines that have been out for a while on survivorship and palliative care that also include whole person care recommendations and principles. I'll illustrate that in just a minute. Let's just look at a couple of these guidelines. One is in pain that says the evidence currently is adequate to say that acupuncture should be offered for AI-related joint pain. That's something Jen experienced. And other musculoskeletal pain conditions, reflexology or acupressure are safe and could be offered as well as massage. Guidelines on anxiety and depression that have come out strongly recommend mindfulness-based interventions of various types to help with the management of anxiety and depression, including things like yoga and other approaches that are safe, such as relaxation therapies, reflexology, and aromatherapy can also be made available. The most recent guideline is on fatigue, and they recommend actually during treatment, after treatment, and even at the end of life, a number of non-drug approaches to help with fatigue, with exercise being one of the leads in those areas, and yet these are rarely offered and rarely done. The ASCO guidelines on palliative care since 2017 have said palliative care visits should occur within 8 weeks of diagnosis. The diagnosis. So for somebody like Jan, that would have been way back 30 years ago. And if you look at some of the essential components of palliative care, managing symptoms are in parallel with some of the other guidelines we talked about, goal discussions, medical decision-making, care coordination in those areas. That this should be a standard part of care. Unfortunately, there aren't enough palliative care, clinicians available, and so this is something that every clinician needs to take under their wing and begin to provide. With the rising cost of treatment, both complementary and conventional health disparities have been growing. And so it's important that this be looked at to make sure we close that gap. Costs are an important part, but also we see that things like psychological counseling and integrative medicine are used less by individuals with less education. There's cultural and religious biases. People are not necessarily trained at providing these things, and they're often less available in community centers. Cultural competency and trust building, relationships, is at the center of care and for closing the gap in equity. And there's now a number of recommendations by the AMA and others for building cultural and linguistic care with humility and bringing appropriate team members in that can actually build trust and a welcoming environment for everyone. And this will help close the gap. Financial toxicity, especially in cancer care, is huge. 4 out of 10 experience that, and bankruptcy often follows because of medical costs in those areas. And this, of course, reduces access and increases disparities. Now, what do we do about all of this? I hope I've made the case for you that whole person care is the care that we have to have across chronic disease management. We started this journey at Healing Works Foundation in primary care, and we started it by taking a whole set of tools to make it routine and regular in primary care settings, and tested this out in 16 primary care clinics around the country. This was published in the Annals of Family Medicine and other journals, and there's a CME program that teaches how to do this. In cancer care, we took those tools then, and for the last couple of years have worked with leaders from a variety of cancer centers around the country. We called them the Integrative Oncology Leadership Group, and translated these tools specifically into cancer care. So they are available in primary care, and they're now available in cancer care. The testing of these tools out in cancer environments has been also presented at ASCO and the challenges, the minimal requirements for doing this, and the challenges as to how to do that. And you're welcome to take a look at some of those presentations at ASCO about how to do this. We've also done case studies, and again, these are available both in primary care and general medicine as well as in cancer care, and I encourage you to look at those. And there's a variety of ways to do this. There's no one-stop shop in terms of doing this because you have to adapt it to your particular environment. Here, for example, is the Aberystwyth Cancer Center. It's part of the University of Pennsylvania, where they changed their survivorship program to make it an actual wellness program. They brought in a primary care physician trained in integrative practices to bridge oncology care and wellness recovery. The Anova Shar Cancer Center has something called Life with Cancer. It started 30 years ago with a small donation. And then it has now evolved and become embedded in the center of their cancer care delivery and is supported by the system. They no longer need to go out and find philanthropy for all these things. And they've partnered with oncologists to bring it into case conferences into those areas. The Sidney Kimmel Cancer Center at Jefferson University in Philadelphia has also created cancer support and wellness centers. They've done the reverse from what UPenn has done by, instead of bringing a primary care into the oncology center, they brought an oncologist into their integrative and nutritional health department where he's providing whole person cancer care in those areas. And they've transferred a tool I'm going to emphasize for most of you called the Personal Health Inventory into Spanish to make it accessible both inpatient and outpatient to those populations. All of these tools, as I mentioned at the beginning, are available on our website. They're all free. Things like journaling for cancer, a cannabis guide, financial toxicity, dealing with neuropathy, with sexual health, etc., on the healing journey. And we've recently made available the personal health inventory. And if there's one thing that you do after this talk next Monday morning, I would recommend you download the general version of the personal health inventory or the cancer one if you're taking care of the cancer patient, and actually just hand it to your patient. Have them fill it out. It takes them 5 to 10 minutes, and it starts this conversation about whole person care. This inventory was adapted from the Veterans Administration for use outside of the VA in the primary care, and then by the Oncology Leadership Group for use specifically in oncology care. And we've also provided a guide for doing something called the HOPE Note, the Healing Oriented Practices Environments Note, to document that conversation and put it in part of the healthcare plan. To make it easier to do this, we've partnered with a company to digitize this. This is called the Smart Measures. And so you can actually send this link to your patients. They can fill it out. There's digital note taking there. It's a secure data storage, it's HIPAA requirement, and you can bring it into your electronic medical record. And it is often free, not always free, because this is a private company, but they provide good discounts and make it very affordable for practices that can't do it. In addition, the pocket guides for doing this in cancer are available both in primary care and in cancer. Here's an example of some of those. These are all vetted by scientists in the leadership group. And we've recently started a partnership with the American Cancer Society where they have begun to pick up the pocket guides and adapt them and put them into their information delivery in their call centers as well as on their website in those areas. And here's a list of some of the ones they're now bringing into that. So these will become largely available to all of your patients in those areas. At our website, all of these tools are available. If you go to our website, healingworksfoundation.org, you'll see the general tools that are available for general medicine, and then there's a cancer-specific one. If you have a patient that's interested in that, they can click the Are You a Patient button, and it will take them to another website where there's information about whole person cancer care, specifically customized for patients that you can use to educate them and make this information available also for them. So on Monday, there's a number of things you can do regardless of where you work at in the system or in the clinic in those areas. And let me illustrate a few of those. If you're a system leader, simply pick up the concept of whole person cancer care and say, we're going to stick it on our quality improvement program, our practice improvement program, and do the things that systems do in order to make it a high priority and innovate in those areas. And there's a list of ways that that happens in those systems. If you're a clinical team or a clinician, the easy thing to do is simply take the personal health inventory, the PHI, try it out. Try it out with team members within your team, try it out with a few patients so that you can get used to how it could be brought into your clinical flow. If you're a person with cancer or a patient, tell your team that you actually want this kind of care and ask them how to get it. This will bring it up higher on their radar screen, and they can look for it within their system or within their community. And if you're a caregiver, be the advocate for them. Especially in the cancer, it gets very, very confusing for individuals, and they need somebody to be with them, to be an advocate, to take notes, and to move them into the empowerment around their own care. If your organization is interested in doing this as a team, we have partnered with Tufts University to create some free CME courses and CEU courses that are available for both physicians and nurses. There's a 15-hour free course for primary care. There's one in pain management, and now there's one that's come out in cancer care also for 5 hours. That's available category AMA category 1 that's available for those teams. And if your team is interested in saying, yeah, we do want to make this a priority and we want to look at how we can implement this within our particular system, Dr. McMahon and I wrote a book about this where we tried to put all of this information together into a simple guide for whole person care and cancer. And there is a book guide also for answering questions and going through it if your team would like to do that. Again, those are available on our website. So we've moved, and many of you have been on this journey for many years, as I have, and we've gone, especially in the cancer care, from what was called quackery and unconventional to alternative to complementary to integrative. And I'm going to suggest that there's now a new way to think about this so that it's not something you get over there, but it's something that you get routinely wherever you walk into care, and that's called whole person care. So thank you very much. I look forward to any kind of discussion and questions that you might have in these areas, and appreciate the opportunity to talk to you today.
Well, Dr. Jonas, that was fabulous. Thank you. So clear, compelling, comprehensive, and personally touching. And if it's okay for me to share what you shared in our discussion beforehand, I think part of your understanding of this whole person health is your own personal journey. And Dr. Jonas shared with me that when he was in medical school, he lived above a Tai Chi master, and every day he would go practice in the park before he went to medical school. And clearly that's shaped your perspective. So we appreciate
that. Got me through medical school, I have to tell you.
Yeah. One question that shows up in a couple of the chats, and it's one that we struggle with here, is the payment. And you mentioned that some of the payment for these things are now being integrated into care, but some of that payment is largely subsidized philanthropy, which may not be sustainable. So many of the programs offered, for example, at the Zakim Center and other places across the Harvard landscape, but many of the hospitals you mentioned come from that sort of soft support. What is needed to sort of shift the paradigm so that this is part of routine care and everyone has access to it, even beyond the transient philanthropic support that's available?
Now, I think that's an extremely important question, and it is usually the first question that people come up with. It is partly a distraction, and I'll tell you that, only partly. Yes, you do need the resources to provide that, and I showed you the problems with financial toxicity when they're not available for patients in those areas. And so you do need to find patients to do that. But in my experience, a lot of the payment for these things, and so so to get those payments, we need new payment models. And in primary care, there is a strong recommendation to move from fee for service or over to capitated value-based care, whole person payment, where you get, in fact, one price for taking care of an individual over a period of time. And then you have built into that the flexibility to address their personal determinants of health. And there's great models out there showing that if you do that and you design your healthcare to actually meet the person where they're at in what matters, you save money. And so you recap those costs. So the reality is, it's not that there's not enough money out there. In fact, there's a lot of money out there, but it's not going into things that drive those personal determinants of health. So reorganization of the payment models is there. Not that fee for service isn't important for for many circumstances in those areas, but some kind of a hybrid model moving to whole person care towards that will get us out of this conundrum of saying, well, you can have 6 acupuncture treatments for that kind of back pain, but you can't have 7. Okay, we need to get out of that. One of the examples that I gave in the cancer area, the Osher area, illustrates the other issue about payment. And that is, a lot of it has to do with the culture. So it's not so much about the money as it is about the mindset. Okay. If these are important, if you agree that the science is there, that the basic science is there, the clinical science is there, the demand is there, then it's a matter of prioritizing that so that you can be creative about those areas. And the Inova Center that started off with philanthropy now uses only philanthropy for doing new things because it's actually been embedded in their culture. It's part of their standard care. It is covered under their operational costs. And so they have moved it in that direction. So I'd encourage many systems to look about how to do that, to change the mindset in those areas. That being said, we do have on our website a payment guide, because many people are leaving money on the table. They're not actually accessing it. So you need to get your coding people involved in this, right? And the training around this. There are ways, for example, to get paid for health coaching. There are ways to get paid for group visits. But people aren't doing that because they don't know how to do that in those areas. And so I would encourage you to look at those coding guides. There's more coding guides. There's more and more of them coming out all the time. I think the physician fee service for 2025 now has new practice management guides built into it that are significantly higher than they have been before. That allows these kinds of management and discussion things and coordination things to be done. So I think there are multiple ways to do it, but first it has to be priority. Then you can figure out the payment part of it.
Fantastic. What a great answer. Comprehensive. I'm going to just shift to my research hat. And I know that you share some of these interests with me. But, typically when we are thinking of siloed medicine and reductionism, we're going after particular symptoms or particular pathological aspects of the cancer journey. But when we think about the whole person health, there are often these complex constellations of things. And the way you design studies to answer complex constellations of things is really different than more reductionist cause and effect. How is your sort of journey into sort of whole person health shifted how you think about how we design sort of research agendas to treat the whole person?
Really, really important question. And I would encourage Harvard to hold a conference on evidence-based medicine, specifically to talk about the methodology areas. Our mind tends to work in very linear things, and we've built a science system, and we've called evidence-based medicine a very reductionistic, can you prove this affects that, et cetera, and our entire reimbursement system from the FDA, et cetera, is all about that. And so we have an engine of folks trying to get incremental changes where you can demonstrate those effects, when we know that healing actually occurs from a systems perspective. But we don't use systems science, which is actually quite well developed, to actually be part of the key science around that area. Evidence is not a hierarchy, right? Okay. Evidence is a house, and you need different types of evidence for making different types of decision makings. And so you can't even talk about something as being good evidence until you first ask who and what is it going to be used for. Once you have that question, then you can go after the right kind of information. And so I encourage people to bring system science into this. Now,
Mhm.
I tried to do this at NIH when I was there. They didn't want to do it. So I went to the Hastings Center, and there was a book published on this actually years ago, but it needs to be revisited again and again. And this is why I'd encourage Harvard to do that.
Yeah,
We might help you do that.
that'd be great.
Evidence-based medicine needs to be looked at this. Now, fortunately, NCCIH and Helen Levan there is actually beginning to move in that direction, right? They have, to her credit, have gotten a whole person systems movement going on, and they just put out their first RFA, and they're going to be funding their centers, and they've gotten multiple other NIH institutes to join this. So this is a movement towards system science and whole person care that's going to shift and could be used to shift our thinking about what is good evidence and for who.
Yeah, well, that's a fantastic answer. And as you know, Helene was our former director. And speaking about systems, I come from evolutionary biology and think of things in an ecological way. And I also want people to know about your earlier work, because just like you've sort of reconstructed Maslow's hierarchy, your house of evidence was a really important construct that really helped a lot of us thinking about this sort of idea of evidence-based medicine. I think we have just time for one more quick question, and then I'm going to do some announcements to close the seminar. But there are fringe therapies out there, and in these traditional practices like Tai Chi and Qigong and acupuncture, we talk about sort of the biofield of the body, that it's more than just material phenomena. And some of this is coming to the fore with really good research. NIH just 2 weeks ago had a conference on the bioelectricity of cancer. And one of the keynotes was a fellow here in Boston, Mike Levin, and he's really interested in the electrical communication between cells and the emergent electrical field. And I'm just curious, this field is so nascent in terms of biomedicine. How do you guide people when they're choosing therapies that are undeveloped? Is there a risk-reward ratio? Or how do you say, no, 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 don't ever do that, or it's worth trying, or I really suggest this, when the science hasn't caught up with the important questions yet, these important questions?
Yeah, well, I think that's very, very important. And there definitely are risks, especially in the area I just talked about in terms of cancer, because people are desperate and they actually go out and try all kinds of things. Some of them are directly harmful, okay? But probably even more important than that, they're indirectly harmful. They take people away from good evidence-based treatments, and people will sometimes abandon those treatments, and that will actually cause significant harm in those areas. So you have to do good evidence in those areas, but you have to actually look at what is the impact and what is the risk. Many of these things are very low risk. And the VA has come up with a good way of approaching these things. There's some where there's evidence that have been put into the whole health program, and there's others where there's not evidence, but they're not going to harm people. So they could be offered as long as they're offered in a way that doesn't result in negating what we know works and doesn't work, or abandoning some other effective therapy, or taking up too much of their time and resources in those areas. But they're not going to directly harm in those areas. Biofield is an example of that. The history of this area has been when we take something outside of the Western paradigm and we begin to put the Western science and mash them together, we come out with some really interesting stuff. Acupuncture is a perfect example of that, right? When I was there, we did a consensus conference on acupuncture, and everybody said, oh, this is crazy. What is this biofield stuff? What is this chi stuff, et cetera? And we now know that acupuncture has a great deal of value, both biologically and clinically, for a variety of types of things. And I think the biofield, this electromagnetic thing, that's part of what has been part of traditional practices for years. Through prana, through chi, through a variety of other biofields. And I think if we mashed our science together with this, we're gonna actually shift to an entire new area of non-pharmacological treatments, if we invest in that research.
Fantastic. Well, I want to thank you again for such a remarkable and comprehensive and inspiring and provocative talk. I'm going to just share my slides again just to do a few announcements to take us all out. But of course, first and foremost, I want to extend one more sincere thank you to Mary Corneal for her support for this named lecture in honor and memory of her beloved Jack Cogan. I also want to alert people to a really exciting seminar next month. We're going to go back to our regular time at 8 a.m. on the first Tuesday, led by Dr. Elise Park here at Mass General. And she's going to be talking about the stress management and resiliency training program called the SMART training program that's really has evolved tremendously to target lots of different populations. And it's going to be a really exciting talk. And Elise's research in this area is really profound as well. I also want to just remind people of a few things that we mentioned at the beginning. Please go to our website, oshercenter.org. You can learn more about and register for our Planetary Health Conference, our High Tech and Soft Touch Network Forum that are coming up. There's information on how to apply to our pilot research grants. You can also access this lecture. In a few days, this will be live, as well as most of our previous ground rounds and prior conferences, including a sort of systems-oriented whole person health, Tai Chi, and Qigong research conference that we held last year with lots of really interesting lectures, including by Helene Langevin, talking about whole person health and connective tissue. You can learn more about our clinic, research, and education programs. And of course, you're welcome to make a donation and support all of these initiatives. And you can use this QR code if you want to do that, or just go to our website. So thank you again to Dr. Jonas, and thank you all for your attention and joining us today. And I wish you all very, very well.